Okay, today we're going to talk about heart failure. So what is heart failure? Heart failure is the inability of the pump to provide enough blood in your circulation so that you have enough blood going forward, but also not having problems of congestion. You often hear heart failure as the term congestive heart failure. And I think it's best to explain to start talking about some of the symptoms of heart failure. The most common is shortness of breath when people exert themselves. And that's because congestion occurs where fluid or blood backs up into the lungs, and that's called pulmonary edema. So that's the most common symptom of congestive heart failure. But there's other ones that include congestion of other organs, such as the liver and your belly, if your belly is being swollen, your legs with edema. If you're concerned that you might have this diagnosis, the one question I'd ask is, are you feeling limited from the things that you used to be able to do? Is your ability to walk through the grocery store impaired because you get tired or out of breath? Or your household chores, you just can't get through them without taking frequent stops? Certainly there's lots of potential causes, but we do worry that the heart may be playing a role, especially in those exertional types of symptoms. A couple ways to diagnose congestive heart failure is one, by taking the history and asking those types of questions and getting those sort of symptoms. Then when a physician examines you, he'll be looking for certain things. He'll be looking at your neck, seeing if there's elevation in what we call the neck veins. That's sort of what I call the dipstick in your car. If you have too much fluid in your tank, then you may have problems with congestive heart failure. Also, your physician will listen to your heart and your lungs. If there's different sounds on your lungs, there might be fluid in your lungs. He can listen to your heart. There might be different murmurs to suggest you have valvular heart disease. That can be a precursor to congestive heart failure. So that's one way. Another way we work towards a diagnosis of heart failure. And then there's different tests that we can do. There's certainly an electrocardiogram, but more specifically, we often like to measure what's called the ejection fraction, or how much that left ventricle is pumping out with each beat. We measure that with tests such as echocardiograms, with stress tests, and that can give us an idea if you have congestive heart failure. Then the other couple tests include blood work. Certainly there's a special protein that's made called the brain natriuretic peptide that can be quite elevated in patients that have heart failure. And then sometimes we have to go to the heart catheterization lab to really define whether or not congestive heart failure is a cause of the symptoms that you may have. So what is the cause of heart failure? Well, the most common cause is high blood pressure. In America, many individuals have high blood pressure, and if that's not controlled, then it can put quite a bit of stress on the heart, leading to thickening of the heart muscle and sometimes even weakening of the heart muscle. And that can be a setup or a precursor to heart failure. Certainly, blockages in the heart arteries can lead to problems with the heart muscle. I describe the heart muscle, the heart, as a pump. And if there's trouble with pumping and the pressures build up, then that will lead to the syndrome of congestive heart failure. Besides heart artery blockages, there might be arrhythmias that can lead to it. Certain viruses can attack the heart, as well as toxins such as alcohol and different chemotherapies. That's just a kind of a partial list, but certainly some of the causes of heart failure. An important aspect when we start thinking about how to treat congestive heart failure is its classification. And so when we classify heart failure, we really classify it based on that ejection fraction. So we have what's called heart failure with preserved ejection fraction, and then we have heart failure with reduced ejection fraction. And so what are the definitions? So anything for an ejection fraction 40% or lower will give you the reduced ejection fraction. We typically think of preserved over 50%. This gray zone of 40 to 50%, we're not quite sure exactly how to approach those patients, but for general sake of conversation here, those are sort of the cutoffs that we have. And so that classification is really important. The also way we classify heart failure is by what we say the New York Heart Association classes. How severe are your symptoms? Mild, moderate, moderate, severe, and severe. And so that also helps us understand which treatments patients will be needing to help with their heart failure. And so based on this, with the heart failure preserved ejection fraction, really the mainstay of treatment is diuretics. Diuretics are water pills that help remove fluid from your system so that the symptoms of congestion, such as breathing and lower extremity swelling, are improved. And these common diuretics include furosemide, also called Lasix, torsemide, also called Demodex, and another one called spironolactone. So with heart failure preserved ejection fraction, we're really left with decongestive type therapies. Also, we're very interested in blood pressure control as well as controlling heart arrhythmias. Now, when it comes to heart failure with reduced ejection fraction, where the ejection fraction is less than 40%, we have a few more medicines in our toolbox, so to speak, that we can use that are very effective. They're effective in a couple different ways. They're effective by actually helping the heart heal, which is extremely important. They're also effective by proving in different trials that they improve people's survival and outcomes with heart failure with reduced ejection fraction. So the first class of medications I'll talk about are beta blockers. And these medications both slow the heart rate and lower the blood pressure, but more specifically, they block hormones that are toxic to the heart. These are epinephrine and norepinephrine, which people know otherwise as adrenaline. And the ones that we use in patients with heart failure reduced ejection fraction are Coreg or Corvedolol, metoprolol, succinate or toprol, and the last one's bisoprolol. And so these are the ones that we know, so that's the class of beta blockers. The next class I put together ACE inhibitors and angiotensin receptor blockers. And these include drugs like lisinopril, captopril, anything that ends in pril, and the angiotensin receptor blockers end in artins, losartan, valsartan. And these work in a little bit different mechanism, again, blocking hormones that we know are toxic to the heart. The third class is just a new one that's come out here recently, are the angiotensin receptor neprilysin inhibitors. And there's really just one drug in this class, and it's called Entresto. It's a drug that contains two medicines in it. One is an angiotensin receptor blocker called valsartan, and the second medicine in that combination drug is sacubitril, which is a new medication that's called a neprilysin inhibitor. And then the fourth class that I'll put in here are called mineralocorticoid receptor antagonists, which is a long name, but these are medicines called aldactone and diplerenone. What we do know with these first three is an important part of your therapy with heart failure reduced ejection fraction is not just getting on these medications, but getting on them on a dose that is the highest that you can tolerate. We know that the higher the dose you can tolerate, the more healing of the heart, the more benefit and protection you'll get out of these medications. So often your doctor will start you on a low dose, make sure you tolerate it, but with each visit try to go up on it. Now sometimes people can't go up on higher doses because they get lightheaded, fatigued, dizzy, and then we know to stop, we can't push too much further, but really our goal is to go up on those doses as high as we can. And really, all these medications have been proven to be very effective in terms of improving patients' lives with heart failure, how long they live, and then often, and the most important goal may be just to heal that heart. And sometimes we can get to the point where that ejection fraction was once abnormal, less than 40%, that we can get to the point where it actually normalizes. And so, so really, it's quite rewarding to have that kind of benefit seen in your patients, in my patients. Besides medications, there are other ways to treat heart failure. There's different pacemakers that are out there. And this comes into play, again, in just patients that have ejection fraction less than 40%. If people have an ejection fraction of 35% or lower, and also an electrical abnormality called the left bundle branch block, then we know that a certain type of pacemaker can actually help patients have improved outcomes with heart failure, as well as potentially improve that LV ejection fraction, get the heart stronger. So that's also another type of therapy that we use in patients with heart failure with reduced ejection fraction. Another type of electrical therapy or treatment is called a primary prophylactic defibrillator, or an ICD. And really, I tell my patients this doesn't typically help the heart get stronger. It's a life insurance policy. Unfortunately, patients that have an LV ejection fraction of 35% or lower are at risk of an arrhythmia that can stop the heart. It's called sudden cardiac death. It doesn't sound very good at all, but there are ways to help treat that in the acute setting if you have one of these implantable defibrillators. So that's another way that we treat patients with heart failure. It may not help the symptoms, but it can actually be used as sort of a life-saving therapy. Two other drugs in heart failure with reduced ejection fraction that I'd like to talk about. One is called ivabradine, also called Colanor. And this medication, all it does is slow the heart rate down. But we do find that in patients with heart failure with reduced ejection fraction, the slower the heart rate, the better outcomes long term. And so there have been clinical trials that have shown that this medication, on top of the background of the other medications, can decrease the number of hospitalizations patients with heart failure have. And it is an important adjunct therapy. I would think these are still considered the backbone therapy for heart failure with reduced ejection fraction, but in certain situations, if that heart rate's still elevated, ivabradine can play a very important role. And then an oldie but goodie that sometimes is used is what's called digoxin. And so this doesn't really have as much of the strong data improving outcomes in patients with heart failure with reduced ejection fraction, but it can help in certain situations in terms of increasing the squeeze of the heart, as well as sometimes lowering the heart rate, especially in people that have atrial fibrillation with their heart failure too. So that may be another medicine that patients with heart failure are treated with. Besides all the medical therapy we have with patients with heart failure, there's a lot that patients themselves can do to help manage their own disease process. And one of those, some of the most important things is monitoring yourself for symptoms. If you start noticing new onset shortness of breath, weight or fluid retention that is worsening, it's good not just to ignore that, but to call your physician, seek an appointment to come in so that you can be evaluated and try to catch things before they get too far gone. And so along those lines, besides monitoring yourself, we do ask patients to restrict how much fluid they take in each day and how much sodium they take in each day. I tell my patients that the heart's playing a trick on the kidneys and it's not delivering as much fluid that it needs, so it's retaining more than it should. And so if you can reduce how much fluid you bring in, as well as the sodium that comes in, then you may not need as much diuretics. You have less chance to have decompensations in heart failure. So that's an important part of your patient management of their own disease process. And then, having that close relationship with your physician or nurse practitioner to call them. Maybe it's a nurse in that doctor's office if things change. Typically with patients with heart failure with reduced ejection fraction, I like to see them every 3 months. But more importantly, if they have had an episode in the hospital where they've had trouble with more fluid on them, more problems with shortness of breath, we do like to see that patient within a week of discharge, and even more frequently within that next following couple weeks, because they're at risk of coming right back into the hospital and having more trouble with their heart failure. So it is a disease that is serious, though there's lots of things that patients can do to help manage them, manage their own disease in close relationship with a physician that helps with these different therapies that we have to help treat you. As I said, patients can really take a huge role in their management and controlling of their disease with heart failure. And there's lots of resources that are out there. And at Christ Hospital, we have a very robust support group where patients come in and sort of just tell their stories and share their trials and tribulations and the things they're going through. And it is an emotional disease process to live through, and it's not just for the patient, but sometimes for their caregivers too. So I often recommend to my patients to bring their loved one with them so they know what to look for as well. So I think that's an important part of the care of the patient, is that support group that we can provide here, and hopefully we can plug you guys into that. As I said, patients can really take a huge role in their management and controlling of their disease with heart failure. And there's lots of resources that are out there. And at Christ Hospital, we have a very robust support group where patients come in and sort of just tell their stories and share their trials and tribulations and the things they're going through. And it is an emotional disease process to live through, and it's not just for the patient, but sometimes for their caregivers too. So I often recommend to my patients to bring their loved one with them so they know what to look for as well. So I think that's an important part of the care of the patient, is that support group that we can provide here, and hopefully we can plug you guys into that.